So thank you very much for inviting me to speak. I'm going to speak basically about the voice today, which is my particular passion. I think aging voice is an interesting topic. The scope of the problem is growing, and this is actually a factor of our medical success. By the year 2020, 2 years from now, 16% of the population in the United States is going to be over 65 years of age. And by 2030, that will grow to about 20%, so 1 in 5 people. Compared to 2010, that is a doubling of the proportion of elderly in our population. So we're getting older, and not only are our populations getting older, older people are remaining more active. It's a different kind of old than we had 50 years ago. People who are still involved very much in various aspects of their lives. Before we get into presbyopia, it's important to note that old people can get normal laryngeal diseases. Old people can get the same types of things that cause hoarseness in young people. We tend to see less phonotraumatic lesions. We see more cancer and precancerous change. We see more neuropathy and systemic neurologic disease, about which we spoke on Saturday. We tend to see a little bit more reflux. But important to understand that just because somebody's old, they don't automatically fall into the presbyopia category. Presbyopia essentially should be considered the main diagnosis only when everything else has been excluded. Right, so this is a typical examination of presbyopia with a low spindle-shaped glottic closure and prominent vocal processes. I think we've all seen this. This is not a mystery. The symptoms are symptoms essentially of glottic insufficiency, of a dysphonia that tends to worsen with use, of a perception of effort, difficulty projecting. The swallowing problems are a whole other subject. And it's something that we haven't been able to do very much about. And frankly, I think our field hasn't done a very good job of addressing it up to now. In the United States, dysphagia is now gaining momentum as a field of investigation and clinical care apart from voice. And it needs to be considered in these patients. Some of the less obvious symptoms is high-pitched voice. This is the phenomenon of paralytic falsetto, where people tend to use the superior laryngeal nerve to tighten their vocal folds and increase laryngeal resistance when they're speaking. There's a decreased pitch in women because there are gender differences in aging. There are gender differences in aging. Women tend to be less prone to loss of muscle mass than men, simply because they don't have that extra muscle mass that's supported by testosterone that men have throughout most of their lives. Many of these patients will complain of dyspnea, and every now and again there's an opportunity to address the dyspnea by helping the voice. And this involves questioning the patient closely. Sometimes patients won't understand that the sense of breathlessness is really related to voice use. And if it's specific to voice use, then really this is not a lung problem. This is a problem of air wasting in the larynx, of valvular incompetence that causes air wasting. And this can improve by addressing the glottic insufficiency. In a community cross-sectional study performed in 2006 in Atlanta, about 20% of patients over 65 reported dysphonia. Now, this was not patients coming to seek care. This was patients in the community. And 13% reported reduced quality of life related to the dysphonia. So this is really quite common. But many patients and many people in general, including your colleagues, your primary care physician colleagues, consider the dysphonia to be a normal part of aging. And they're not aware that this can be addressed. They're not aware of the potential for improvement for these patients. And part of that is education. We need to educate our geriatrics colleagues, our primary care colleagues, that there's help for these people. The main issue that we're going to contend with today, the main issue that we have the capability to contend with in the year 2018 is sarcopenia, the decrease in the muscle fiber size that takes place beginning around age 55 or 60, and which results in functional changes. But it's easy to reduce presbyopia to that because this is the only thing that we have a treatment for. The expression in English is, when the only tool you have is a hammer, everything looks like a nail, right? So there are many more problems in this with aging voice, but we only have the hammer right now. So I want to review sort of the entire integrated sequence of voice production so that we don't lose sight of the fact that there are other things going on that may be able to be addressed in the future. Voice production depends on air pressure, which is generated by the diaphragm and the chest wall muscles with exhaled air. It depends on the integrity of the oscillator that changes regular exhaled air into sound. And the voice quality also depends on the various qualities of the resonating cavity, which is the pharynx, the nasal cavity, and the oral cavity. And all of these things have to be very tightly integrated to produce connected speech. There is potential for all of these to degrade with time. There's clearly a decrease in pulmonary function as we get older. And there's been a documented loss of coordination between the laryngeal and respiratory movements. We all know the phenomenon where the vocal folds are entrained with the muscles of respiration. This tends to break down over time. This is not as automatic as it is. The innervation, the nerves themselves change in that you see all the histologic changes that are present in the nerves as you get older. Basically, we lose conductive efficiency in the nerves. Conduction times slow. And these are peripheral changes. The central changes are probably even more profound in their implications for function, and we've only begun to understand them now. There are changes in the resonating tract. There are dehydrating effects of many medications that people may be on, antihypertensive medications, diuretics, anticholinergics, and so forth. There is the degradation of the articulatory structures, the teeth. And then there are also intrinsic changes in the larynx. The cartilages become more ossified. There's been some evidence to show that the joints lose range of motion, and the properties of the mucosa change. The lamina propria thins, and this is very, very specific to men. We don't quite understand it, but at least in the early stages of female aging, we tend to see the opposite. The lamina propria actually thickens, so that early stages of female aging can actually be marked by a drop in pitch, which is not the case in men. There's a decrease of elastin fibers and hyaluronic acid, which changes the rheologic properties of the vocal fold and demands increased air pressure apart from glottic insufficiency, demands increased air pressure to drive the oscillator. And there's a disorganization of collagen that also tends to stiffen the lamina propria. Important also, we talked originally about sarcopenia. We're going to come back to that because one of the main problems that we have is atrophy of the muscle. When we examine the larynx in the office, it's very easy to fall into the notion that the vocal folds are like windshield wipers, that it's a two-dimensional structure. And they're not. And we need to remember this when we rehabilitate these patients. This is a cross-section from Gail Woodson's nice chapter on laryngeal aging, which shows that the loss of muscle mass changes the cross-sectional area of the vocal fold. Why is that important? Well, the maintenance of the Venturi configuration is important for phonatory efficiency. And when you lose that convergent glottis and it turns into more of a two-dimensional structure, that efficiency decreases and you need still more air pressure to drive the pulmonary apparatus. So all of these things conspire to produce a situation where you get less output for more effort. And this is the general theme with laryngeal aging. On laryngoscopy, the typical signs of the vocal fold concavity referred to as bowing. I don't like that term because bowing doesn't really distinguish between atrophy and hypotonia. Hypotonia is an entirely different neurologic phenomenon where the muscle is there, but it doesn't tone. Atrophy refers to loss of muscle. The vocal process becomes prominent, not because it grows, but because the soft tissue around it recedes. And sometimes patients will be sent to me because there's a quote-unquote mass on the vocal cord. And what happens is that the vocal process is mistaken for a lesion because it sticks out so much. This, again, represents a predominantly male pattern of laryngeal aging. Women are much less prone to atrophy for the simple reason that their muscle mass in youth is less sustained by hormonal factors as it is in men. So in a way, there's less muscle to lose because of hormonal factors. So we do see atrophy in women, but it tends to be a later phenomenon. And in my experience, not nearly as symptomatic as it is in men. Not nearly as symptomatic as it is in men. Women do develop an atrophy of the lamina propria, which drops the pitch, rarely severely enough to drive them to the doctor's office. In New York City, where there are a lot of people with too much money and not enough sense, there's a fashion now to supplement testosterone in women. And this is done by plastic surgeons or cosmetologists, and people tend to like it because they feel like they have renewed energy. And I do see a run of women who come to my office asking why their voice has gotten deeper. And this is sort of a collateral problem of aging, collateral damage from something else that's used to address this. And of course, they've been assured that this won't have any effect on their voice whatsoever, and of course, it does. Right, so this is sort of a sequence of events that shows the typical atrophy of the vocal folds. And here you see the vocal process. For somebody who doesn't look carefully, I suppose that could look like a mass. It happens more often than I'm always surprised that I get as many patients as I do with the recommendation to excise the vocal process and that's to operate. And of course, we don't do that. So when do we intervene on these? It's really a symptom-driven intervention. This is a normal phenomenon, so this is not pathology per se, but it yields a functional deterioration. And the severity of the functional deterioration is really up to the patient to decide, and not always in line with what we hear. Sometimes these cases look relatively mild, but the patient finds it quite severe. And I think the difference is that the patient has, the one thing that we don't appreciate is the patient's own sense of effort. And very many patients are bothered less by the quality of the voice and more by the sheer effort required to, if you're a college professor, to get through a lecture, if you're an attorney, to get through a case in court, and they come for this. Also important to note that this doesn't automatically require surgical intervention. This doesn't automatically require surgical intervention. Our therapeutic options essentially are voice therapy. In voice therapy, the voice therapists work on strengthening exercises. They work on integrating neuromuscular control, or I should say reintegrating neuromuscular control. It's not clear that any change in muscle bulk results. It's not like going to the gym. But certainly a voice therapist can do a lot to teach a patient how to get the most output out of a given system, even if nothing about the system changes. And I would say that voice therapy is probably the first-line treatment with some exceptions for the aging voice. The improvements are modest, and it's really extremely limited by the amount of atrophy. So if you have a great deal of atrophy, just as in vocal cord paralysis, if there's a big glottic insufficiency, voice therapy essentially won't make any difference at all. It does better with relatively mild deficiencies. It also requires multiple visits and sometimes maintenance revisits. Not always the easiest thing for elderly patients, especially if they don't live close to the hospital. So sometimes that can be an issue. The surgical options are two, injection augmentation and framework surgery. And one of the things I keep coming back to, almost any talk anybody asks me to give is awake vocal fold injection in the office. And it's particularly well suited for this group of patients that may have comorbidities and probably will need repeated injections over the years, and they won't be getting any healthier. So being able to inject these patients in the office is a tremendously good tool. Now, we don't have any permanent injectable materials except for perhaps fat, and that one you can't do in the office. The framework surgery is simply an adaptation of the framework surgery that we do for vocal fold paralysis, in which essentially we subtract the originoid surgery and add contralateral implant. So we do a bilateral medial-facial implantation. Let's go through these. There are many, many different approaches to the larynx. One of the points that I always make when I get approached by pharmaceutical or equipment companies for device development is that the larynx is an extremely accessible organ. We really should be probably applying more local treatments to the larynx because, like the eye, it's not hard to get to compared to some other organs. And I think there's a real opportunity for local treatment. There's a whole series of approaches. The oldest one, of course, is the transoral approach. This is Wilhelm Bruning's. Everybody knows the Bruning syringe. That's a syringe he developed to inject paraffin in 1911, so more than 100 years ago, through the mouth. The advantage of injecting through the mouth is that you get to see the needle all the way through. The disadvantage is that the entire anatomy is built to keep things out of the glottis. So you're fighting the natural configuration of airway protection. Obviously, the patient gets a topical anesthesia, and in contrast to Wilhelm Bruning's, who did this one-handed while holding the tongue with the other hand and using a head mirror, we typically make this a two-person procedure where the assistant drives a flexible endoscope to the nose for visualization so that we can concentrate on maneuvering the needle. I find this very difficult. My favorite technique is through the cricothyroid membrane. We bend the needle a little bit, go up and lateral, and inject the adductor muscle compartment. We can stay entirely submucosal. This is very natural for me because I'm a Botox injector. For spasmodic dysphonia, we use the same approach. In place of using EMG, we again use an assistant with a flexible scope who can show us what we're doing. I'll show you an example of that in a moment. The landmarks are really very, very good in the larynx. Everybody can find the cricothyroid space. That's where you do the emergency airway. The transthyroid approach comes from above. This has special applicability in elderly patients because sometimes the elderly patient is kyphotic. And you have this type of look, and the larynx tends to be tilted forward. And it's a little perverse to try and get in it from below. So coming at it from above comes very, very natural in some of the elderly patients. This is how the approach looks on a cadaver study. You enter the thyroid notch and the needle comes out somewhere around the petiole of the epiglottis. Obviously for this it needs to be topicalized. You can also go through the cartilage, and sometimes we pick up cartilage plugs. This is an example of not aging voice, but a paralyzed vocal fold in a woman with vagal palsy. This is her pre-intervention examination. I'm going to try and connect the sound here. When I did this yesterday, bad things happened. Let's see. Well, there's no sound. Okay. So that's an examination, I think, that everybody knows. What you'll see on the video is you'll see it's a little dark. You'll see the needle enter the airway. It'll go into the vocal folds from below, and then you'll see an expanding white mass. We're injecting calcium hydroxyapatite in this patient. So there's the needle right there. And now watch this space. You see this is very well tolerated by the patient, and in fact, I think I have over-anesthetized this patient because normally we don't like to see so many secretions in the airway. It is possible to over-anesthetize patients, and then unfortunately they get to clearing their throat all the time. So then we're done there. That's the end of the procedure. And 2 weeks later, trust me that she sounds better. There's no sound, but you can see that the contour of the vocal folds improved. This is a very nice thing to be able to do in about 5 minutes for a patient compared to how we used to treat this. All right. So this is an example of vocal fold atrophy, and a little bit clearer, we're entering the airway in a subluxed, and we're entering the vocal fold. And in this case, we're using methylcellulose. Methylcellulose is a very temporary material, lasts about 8 weeks, but also has no potential for permanent damage. So if you're just starting to do this procedure, this is a good material to start with. It's very forgiving. With experience, as you see there, we're getting our injection in now. With experience, you can stay entirely submucosal, so you don't even need to topicalize the larynx. I will say it is very important that you are certain where your needle is. By way of caution, I'll tell you there has been a death, not mine, but there's been a death during this procedure when someone was injecting a very thin neck, was absolutely confident that their needle must be in the right place, although they didn't see it, and they ended up embolizing the superior thyroid artery and the circle of Willis, and the patient died immediately. So I mentioned that just to tell you to be sure where the needle is. How can you be sure where your needle is? Watch this space. You'll see us move the needle back and forth before we inject. And there's no sound here, but I'm having constant dialogue with the patient and with my assistant to let them know everything's going okay. I tell them about, sometimes they can get referred pain to the ear via Arnold's nerve, but I warn them about that so they don't startle, and then we are doing the injection. There's also fat that you can do in the operating room. I'm not a big fan of fat because it is extremely unpredictable, but I think it does have some applicability in certain of these patients. Okay. Where do you inject? As far lateral as you possibly can. There are 2 landmarks to keep in mind. The line of the vocal process and the superior arcuate line. Typically when we do vocal fold injections, for paralysis, we tend to want to move the posterior vocal fold over so we inject at X1. In presbyophonia, because you're treating atrophy, it may be helpful to move the injection anteriorly a little bit. You can do both of these just to make sure you have good filling. With mobile vocal folds, sometimes you need a surprising amount of mass, a surprising volume of injectable. All right. So, I think the benefits are obvious. One of the ways in which this is uniquely beneficial in these patients is that many of these patients are reluctant to undergo medialization laryngoplasty with an implant. And the injection gives them a sense and gives you a sense of the doctors how much benefit can be achieved. As I mentioned earlier, aging larynx is a multifactorial problem, and sometimes you miss the significance of factors that you're not treating by doing an injection augmentation. An injection augmentation is surprisingly unhelpful. For the doctor. More of the time, the injection augmentation is more helpful than the patient expects it to be. And it helps them to see how much the augmentation makes a difference for them to make a decision about how they want to go forward, whether they want to keep getting injections or whether they want to proceed with brain surgery. All right. Framework surgery is the only reliably permanent method we have of closing the glottic insufficiency. We talk about it being permanent, but remember that the atrophy is an ongoing process. So yes, the implant is permanent, but the goalposts are moving. So sometimes if there's additional atrophy, an implant that was done 5 years ago isn't quite as effective as it was to begin with. Of course, we don't do arytenoid abductions because the vocals are mobile, and we do the operation bilaterally. In comparison, more predictable results with medialization laryngoplasty. Injection can be done in the office. This is permanent and better at large gaps, and this is temporary and better at small gaps. All right. The concept, I think, is simple. Simply put in a mask in the paraglottic space that pushes the vocal fold over. In this case, unilaterally, we do it bilaterally. Essential to have both visual control and to check your results by ear. The reason visual control is important is because lying on your back on an operating table is not necessarily a real-world situation. And you can make the voice sound fine in an operating room, but it doesn't work that well in real life. So you do need to see what you're doing. This is the typical Vanderbilt setup. I typically don't leave the flexible scope in the entire time. I'll have my assistant put it in right when we're putting in the implant. And we do it in such a way that both of us can see what we're doing. Incision over the lower border of the thyroid cartilage. We make a window. If you use Gore-Tex, the specific size of the window is not so important. These images show the Netterville set, which is made to be used in Silastic. We make the window a little further back in men because this angle is more acute and there's more of a chance of perforation anteriorly. And women about 5 millimeters back from the brow. Try to orient the window parallel to the direction of the vocal fold. When you look at these images, you say, how could you be so stupid to make this mistake? The reality is you don't have this exposure in the operating room. And sometimes you misjudge the way the radial cartilage is angled. You get some help when you have an indwelling scope because this is the light from the scope on the inside. We remove the cartilage. We measure the displacement. This is, again, more important if you're using Silastic because you have to carve the implant. With Gore-Tex, you simply accumulate the implant more and more, so you don't even really have to pre-measure. You just have to make sure your window's in the right place. And then you start layering in the Gore-Tex until the voice sounds a little bad and you withdraw a little bit. Yeah. And this is the importance of endoscopic control. Here we are trying to see where we are in relation to the vocal fold, and you'll see that we have and you'll see that we have just a little, we see that we have displacement right at the original, which is exactly where we want. So this is very, very helpful, particularly when the case doesn't go well. It tells you how to modify your approach. Okay. Which implant do you use? You can't really use any preformed implants because they tend to be too big. You've got to use an implant that you have some control of the size over. I happen to use Gore-Tex simply because I was trained that way, and as in all surgeries, you develop the facility with a specific technique and material, and after you've gotten good at it, you're very, very reluctant to learn another material. Right? It's very possible to get good results with Silastic. The philosophy is a little bit different. With Silastic, you start big and carve down. With Gore-Tex, you start small and build up. The end result is very, very similar, and they're both flexible enough and variable enough that you can adjust them to these situations of glottic insufficiency. With the Gore-Tex, as I said, you simply just layer it up. Okay. Important to have the patient really not that sedated. I usually tell the anesthesiologist that just use a little benzodiazepine because I need the patient to converse with me. They need to be really very, very, very awake. Typically for these cases, unless something unusual happens, we don't use a drain and the patient goes home the same day. This doesn't have the same risk of airway obstruction as an arytenoid adduction because the thyroid cartilage tends to protect the airway from any hematoma that might form in the neck. So, In the future, we probably will have growth factors to counteract the sarcopenia. We'll be able to inject autologous myoblasts. There was a very interesting study done by my colleague Peter Belaski at the University of California, Davis, with autologous myoblasts for tongue atrophy in sheep. He was interested in correcting the tongue atrophy in amyotrophic lateral sclerosis. And he was able to actually improve muscle bulk in animals. So that may develop going forward. And then the pacemaker has come along. And the pacemaker may help us maintain muscle bulk and tone beyond what would otherwise happen. So the laryngeal pacemaker is currently in trials in Europe for tracheostomy-dependent bilateral vocal fold paralysis. And I expect to see its applicability improve. So I hope that's given you something to think about. This is a significant quality of life issue, and I have to tell you that every now and again you do one of these procedures and the effect is transformative. I've particularly seen this in patients with very, very early stage dementia, where they sort of become withdrawn because they can't interact, and the family brings them, and the family doesn't even have a sense that it's a voice problem. They'll say that Papa doesn't talk anymore, you know? And you look, and he'll talk to you, and you see the atrophy, you do the injection, and it's transformative. The patient becomes interactive, the patient brightens up, the whole relationship with the family is improved. And then also for patients who are frustrated because they want to continue to work and they can't do their work, like college professors, and I mentioned attorneys, this happens a lot. This is a symptom-driven intervention. We have options to suit almost every clinical situation. Not to forget, this is a little one-dimensional because we're only treating muscle atrophy, but improvements are coming down the pipe because our patients are going to demand it. There's more elderly patients who want to remain active. Thank you very much for your attention. Please check out our website for more information about these procedures. And I'm happy to take any questions if we have time.